My name is Maria Virginia Villegas. I am an infectious disease. I have a master in microbiology and I have a research fellow in bacterial resistance. And I work in Bogota at the Universidad del Bosque. I do nosocomial infections and antimicrobial stewardship for a network of 40 hospitals in 14 cities in the country. But I also collaborate with other hospitals and other countries trying to figure out which are the most common mechanisms of resistance so everybody knows what's going on in their own country, in their own city, in their own hospital, and use the antibiotics correctly for the right patient, for the right bacteria, as soon as possible. The burden of antimicrobial resistance in Latin America, you can say, is from Mexico to Argentina. All the countries have problems. Maybe they have different problems in the sense of the carbapenemases that are prevalent in their own countries. But after the pandemia, the COVID pandemia, what we saw in all of the countries was that one bacteria can harbor two plasmids that would allow that bacteria to become resistant to many antibiotics, and those are mainly carbapenemases of two different types. So that's why it's so important to have genetic characterization of the bacteria or have rapid diagnostic tests, because that would be the only way to know which is exactly the mechanism of resistance that that bacteria has, and then you can approach with a different therapeutic antibiotic. So what we saw after the pandemia in most of the Latin American countries, from Mexico to Argentina, even Chile, who for many years didn't have so many carbapenemases. So as you can remember, the carbapenemases are an enzymes that come into the bacteria in genetic elements. So they reproduce the information that is there, so the bacteria becomes instantly resistant to many antibiotics, if almost all of the antibiotics many times. So what we saw was the fact that the most prevalent carbapenemase was KPC, which is described in the world, but then a metallo enzyme, which hydrolyzed more antibiotics, came to the panorama after the pandemia, and both of them can be in the same bacteria, which limits, in many countries in Latin America, the therapeutic decision, because many antibiotics are still not in those countries to give the right antibiotic for the right bacteria. So why is so important to have a way to make a diagnostic about the mechanism of resistance? Is precisely because if you don't give the right antibiotic, the patient will have a much higher possibility of dying, especially with sepsis, bacteremia, septic shock. So rapid diagnostic test has become like the gold standard when you do antimicrobial stewardship, which means you're choosing the right antibiotic for the right patient and you're building this antimicrobial guidelines. So you need to know exactly which are the most common bacteria and which is exactly the mechanism of resistance. What kind of carbapenemases do they have? One of the things that you have to take into account when you're an infectious disease, a microbiologist, or running a program of antimicrobial stewardship, is that the antimicrobial susceptibility tests, which are the ones you do when you have a culture and you have the bacteria and you test the bacteria for many antibiotics, is that this kind of bacteria, which has a carbapenemase, can become resistant to all the antibiotics, but you don't know exactly the mechanism. So that makes a huge difference. First of all, because it's important to do cultures. It's important to have the antimicrobial susceptibility testing. That's perfect, because that will help you a little bit decide certain de-escalation, etc. But if you don't have the mechanism itself, which the only way is by rapid diagnostic test, first of all, you can have a result when you have a blood culture and it's positive in 1 hour. But the cultures will take 72 hours. So if you don't have a rapid diagnostic test, you will miss the bacteria and the mechanism for 3 days. So if a patient is in a sepsis or a septic shock, not having those results soon will basically make that the patient, you are wrong with the antibiotic and the patient can die. The limitations are the way the hospitals and the administrator think about the cost, But it's not the cost, it's the value. And most of these tests are cost effective because when you have the right bacteria, you give the right antibiotic, you are not losing time, plus you're not giving other antibiotics with secondary effects. The patient will get well sooner, so that means less days of hospitalization. So I would say the limitation basically is the machine that you need in the hospital, the fact that the administrator knows the value of this and doesn't go by the price. It has to go by the value of what the meaning of having a rapid diagnostic test. So when you are in an environment in the hospital that has bacteria that are highly resistant, like Enterobacterales with carbapenemases, you need a rapid diagnostic test. Because in patients with septic shock, patients that are in the intensive care unit, for every hour you delay the treatment, it has around 9 to 10% of possibility of dying. And if you add the fact that you give the wrong antibiotic, you can get up to 70% of mortality. So it's very important in the sick patient with all the comorbidities that they have, if it does have a bloodstream infection, you need that as soon as those cultures are positive, it doesn't take 72 hours for the culture to grow the bacteria and show you what is susceptible or what is resistant. So in that point, rapid diagnostic test makes a huge difference because once the blood cultures are positive, you can have in 1 hour the bacteria and the mechanism of resistance. So when you have a rapid diagnostic test, it's not only making a quick decision about what antibiotic to choose, but this rapid diagnostic test will tell you how resistant the bacteria is, and it's a highly demanding in the sense that a bacteria that is with a carbapenemase, it will spread in the hospital quickly, what we call cross-transmission between patients, because no matter if the doctors wash their hand and you clean, those patients sometimes have to share the same room in many Latin American countries, and even the bacteria stays in the surface of the hospital. So if you touch the surface, you don't wash your hands, you will keep giving that bacteria to other patients who can be even sicker. So what you need to know exactly, and you do with rapid diagnostic test, is as soon as I have the result, I will tell the infection control to start contact precautions. And contact precautions have shown to stop the cross-transmission of these bacteria. The data that we built in the hospitals based on antimicrobial susceptibility and rapid diagnostic tests will help me create antimicrobial guidelines. And antimicrobial guidelines are very important because once a patient spikes a fever and you suspect a bacteremia, even before the blood cultures are positive and I can use the rapid diagnostic test, I will start empirically antibiotics. And that's based on the data I create with the cultures and the rapid diagnostic test. So I will know exactly what is the possibility of that patient having a multi-drug resistant bacteria. So in the hospitals, there are two key topics that everybody's trying to implement. One is antimicrobial stewardship, which is optimizing the antibiotics you give to the patients. But the other one is diagnostic stewardship, which means choosing the right methodology or the right lab test for that patient in order to have the results as quickly as possible and implement all those things we're talking about, infection control, the right antibiotic for the right patient at the right time. So that would be saving lives. But also the diagnostic role is key for the hospitals because it's the only way that you can have data, you can create your antimicrobial guidelines, you can give the right antibiotic to the patient. So those two have to work together in order that the results and the data that you have really benefit the patient and the hospital.